Well, good morning, everyone. I want to welcome all of you to the Bipartisan Policy Center. My name is Anand Parikh. I'm the Chief Medical Advisor here. Welcome to today's event entitled Reinventing Rural Healthcare, a case study of 7 upper Midwest states. For those of you who are new to BPC, our mission is to actively seek to combine the best ideas from both parties to promote health, security, and opportunity for all Americans. We drive principled and politically viable policy solutions through the power of analysis, negotiation, and advocacy. Today's event is being streamed live online, and a recording will be available later today. We invite you to interact with us on Twitter about today's event using hashtag BPCLive and the handle BPC_bipartisan. We'll also be taking questions today after both of our panel discussions. If you're watching online and have a question for any of our participants, you can tweet at us and we'll try to get to those during the question and answer. We're gathered here today to focus on the 46 million Americans, 15% of the U.S. population, who live in rural areas. Areas that comprise 72% of the nation's land, 15% of the American population residing in 72% of the nation's land. Rural Americans are older, have comparatively more disease burden, and lower per capita income. Shortages of healthcare workers and geographic challenges, including terrain, harsh winters, and distance to emergency services, make it all the more difficult for people living in rural areas to address these challenges. But as Daryl Birch, who you'll hear from shortly, a CEO of a critical access hospital in North Dakota, once said, quote, "Just because we live in rural areas in this country, we shouldn't have to settle for anything less than the best healthcare services," end quote. It's in this spirit that the Bipartisan Policy Center, in partnership with the Providence Center for Outcomes Research and Evidence, launched an effort in 2017 to better understand the needs, opportunities, and innovative efforts of those working on the ground in rural communities to improve patient care. During this project, BPC focused on 7 states in the upper Midwest region of the United States: Iowa, Minnesota, North Dakota, South Dakota, Nebraska, Wyoming, and Montana. In this effort, we are very thankful for the support of the Leona M. and Harry B. Helmsley Charitable Trust. Today, BPC is issuing a report which identifies 4 specific themes for policymakers that require attention. BPC believes these learnings also apply to rural areas across the United States. The 4 themes are: number 1, healthcare services need to be right-sized to fit community needs, and not vice versa, where services define communities. Number 2, funding mechanisms and payment models should reflect the unique challenges that rural areas face. Number 3, local pipelines for young people need to be supported to build a 21st century workforce focused on primary care. And number 4, telemedicine can be a great tool not only for patients, but also for provider recruitment and retention. Remaining barriers and challenges need to be addressed. Today we'll explore these themes in greater depth with 2 panels, the second of which will consist of healthcare experts from the upper Midwest who have traveled here to be with us today. At this time, I'd like to introduce our first panel. We're very pleased and honored this morning to host Senator Heidi Heitkamp and Senator Mike Rounds. Senator Heitkamp has represented the state of North Dakota in the U.S. Senate since 2013. She is currently the co-chair of the Senate Rural Health Caucus and has introduced a number of bills during her tenure to improve access to affordable care in rural communities. A lawyer, she was formerly Attorney General and Tax Commissioner in North Dakota, and also a successful businesswoman in the private energy sector as well. Senator Rounds has represented the state of South Dakota in the U.S. Senate since 2015. He previously served as the 31st governor of South Dakota from 2003 to 2011, and before that served in the South Dakota State Senate and also built a successful insurance and real estate business in the private sector. We welcome back the senator to BPC, where he previously served on BPC's Governor's Council and co-led BPC's health project with former Senate Majority Leaders Tom Daschle, Bill Frist, and former Governor Ted Strickland. Moderating the discussion with the 2 senators is BPC President and founder Jason Gourmet. And so at this time, please welcome the senators and Jason Gourmet to the stage to get us started. Thank you.
Good morning, everyone. A lot of this discussion is about the challenges of isolation and the difficulty in getting to essential services. And I'm talking about the inch of snow in Washington. My children's school were closed today, and I think when it talks about the hardiness of the people to my left, Senator Rounds is indicating that school never closed. Senator Heitkamp told me that the kids go outside as long as it's at least 10 degrees below zero. Our little flowers are not let out the door if it's under 43. So I say this because it does provide a little bit of insight into the different kind of ethos between this kind of Amtrak corridor and the people who live in these frontier areas. And I think it speaks to the fact that the solutions that we have identified are going to be very different, and in some ways potentially much more efficient than what we have designed for healthcare in much of the rest of the country. So let me start off with a couple of general thoughts, questions. Senator Heitkamp, you are the co-chair of the Rural Health Caucus. You may have noticed things are a tad partisan these days in Washington. Do you see rural health care as an issue that has the potential to provide a kind of more united front? And what are the issues that might drive that process?
I think it's interesting because when you talk about rural health care, it's virtually impossible to have a real meaningful discussion without talking about the challenges of rural America. Higher poverty rates, more isolation, less transportation, aging population, and now we have challenges in the ag economy with low commodity prices, and in our states, a growing concern about drought, which is huge. And so I don't think that we can really talk about healthcare unless we talk about meeting all the challenges of rural America. Now, on top of that, when you look at private employment in my state, basically the largest private employer in a state like North Dakota is in healthcare. And so not only do we have the challenges of rural healthcare, we know how critically important providing that healthcare is to the economy of our state. And you'll see that all across the region on the states that you've identified. I will tell you that rural versus urban issues aren't as much partisan issues as they are jumping up and down and saying, look at us, look at us. And I think the introduction was so well done because when you're looking at 15% of the population, which is in 70% of the land mass of this country, you know that you have a hard time getting attention. And that's why I always tell people, I get up every morning and my first thought is, what am I going to do for rural America? Not rural health care, but we can't have rural America without rural health care. I think one of the frustrations that I have with how we deal with policy issues in Washington, D.C. is we revisit the same issues over and over again. And we saw that with the doc fix. We see that with 430. We see that with physician supervision. We see that with 72 hours. I mean, I could go through the whole list. And you say, if we fixed all of those things and gave you permanency, that would be a good thing. Let's admit that. That'd be a good thing. But it won't solve the problem of dealing with rural health care. And that's why the work of this commission and committee is so critical. That's why we want to thank the Helmsley Foundation for focusing on rural health care, because it's hard to get foundations to really focus on places like ours, like North Dakota. But I think we need to do what I call look up. And Darrell will also talk about the work that we've been doing with the Hospital Association with healthcare providers. I started right away with an advisory committee on healthcare. And my challenge wasn't just tell me what you need right now. My challenge was look up, what do you guys, how are you going to do your job of providing healthcare into the future in 5 years, in 10 years, in 20 years. And it's going to have to look different than what it looks right now. But I think you've identified the right challenges, but I think we need to be driving a proactive strategy in rural health care that doesn't just fall back on the easy, 1, 2, 3, 4 that I just gave you, but actually talks about systemic change and fighting for a different way of delivering and paying for healthcare services in rural America.
So, Senator Rounds, You were governor for almost a decade. You've seen a lot of these issues right up front. Can you speak to a couple of the specific challenges that you believe the country has to engage to provide the kind of support necessary?
Well, first of all, let me just say thanks for the opportunity to come back in and to visit with the Bipartisan Policy Council. I can tell you that right after I was governor, I was a part of the organization up here, and I thought that you brought a lot of credibility with regard to the discussion of these particular types of issues. I also wanted to say thanks to the Helmsley Trust as well, because what they have done for us in rural America is critical. They have already made a true and dramatic change in the healthcare in the upper Midwest. Walter Panzer is here today, and it's great to see Walter. I've worked with Walter since the time that I was governor in South Dakota. And the Helmsley Trust has made a huge difference in rural America healthcare already. Numbers count, and I think you're going to be able to disclose some very, very good numbers today. And I also just want to mention that what you really talk about here when we talk about the federal versus the rural and what the feds can do to assist or to make it easier for healthcare to be delivered in the rural area, there are a number of areas that I think we should be talking about. Let's just begin with stability. And by that I mean, we're going to talk today, we're going to have the announcement today of another continuing resolution. The continuing resolution that's being proposed is to go from January 17th today, or the 19th, until February 16th. And my question is so where does that get us? It doesn't provide any stability for rural health carriers, doesn't provide any stability for the hospitals, doesn't provide any stability whatsoever for folks that look at contracts with the federal government. And yet here we are just kicking the can down the road another couple of days. That's because we haven't found the necessary gumption to actually come together and make some agreements among ourselves, Republican and Democrat, conservative and liberal points of view. We've got to live in this country, and yet we find ourselves struggling just to get by day to day. It's a terrible example to the rest of the world of what should be stability in our great country, and it's time we face that. So let me just start. First of all, we can offer stability, and that's critical here at this point for those healthcare providers. Second of all, I really do think we have to address some of the challenges yet left over from the Affordable Care Act. In rural areas, when I was governor, we had, now get this, we had 17 companies offering group insurance coverages in South Dakota. We had 13 companies offering individual individual coverages in South Dakota. Today we've got 2. And part of the reason for that is when you make it more difficult for companies to actually do business and to compete with one another, they leave, they go elsewhere. And the capital that's behind them leaves as well. Today, when you take a look at the Affordable Care Act and what has been delivered, while the goals were admirable with regard to providing the best possible coverages and care that are out there, you're not finding it necessarily delivered to some of those people who right now can't afford to buy it. I think we've got to find a way through it. I think Senator Alexander and Senator Murray were providing a very reasonable approach to stabilizing the health insurance market, which would really help in rural parts of our country where in some cases there may be only one carrier available in an entire state. I think in North Dakota, I think we've got 3. In South Dakota, we've got 2. But I think we have to address it. We can't walk away from it. We can't simply say, well, we can't get anything done, so we're not going to do anything. I think we've got to continue to work and find some common ground with regard to a long-term and stable healthcare solution. The answers are out there, but it's going to take some agreement among people with differing points of view. And we start by actually passing a budget and appropriations for more than 1 month at a time.
I'm guessing there's quite a bit of agreement with that basic premise. Senator Heitkamp, you called on the senators for Medicaid and Medicare, CMS, to form a rural health council, I think in part informed by the challenges Senator Rounds was indicating about Congress's ability to move forwards. Do you see the opportunity to collaborate with the executive branch to advance some of these issues absent legislation?
I think one of the frustrations that we always have in rural America is the one size fits all. Whether, as Senator Rounds and I are engaged in a banking reform bill that is directly related to this problem of Dodd-Frank being too big to fail, becoming too small to succeed. And it has greatly contracted mortgage lending in rural America because of the inability of affordability of compliance burdens. So I think that's a great example where we can work together to identify those things that don't work in rural communities. That where reimbursements need to be redesigned in rural communities. One of the great challenges that you've identified that is that if you talk to anyone in rural America, it's transportation. How do you get people where they need to go, or how do you get personnel to where the people are to basically provide a quality health care product? And so what I would say is that we need CMS to be flexible. We need them to understand that we're not trying to deliver lower quality care. And I appreciate so much in the introduction Daryl's comment, that we're committed to providing the highest quality of care, but we need the flexibilities to do that. And one size does not fit all. And so as a result, we've pushed the last administration very hard to have a unique look at rural health care. I think this administration is continuing that work. We're grateful for that. And we think some good things can come out of it, but they won't if we simply hunker down in rural health care and say, fix these 3 things or 4 things and our problems go away. Our problems are not going to go away until we get systemic reform. And, Senator Rounds talked about the Affordable Care Act. Well, I'd be curious with the healthcare providers who are here, what percentage of the healthcare that you provide is Medicaid or Medicare? So that private insurance market, albeit critically important, is not the only thing that we need to look at. And the federal government is critical, and federal reforms are critical to delivery of rural health care. As we said, it's an elderly population, and they're going to have higher costs, and they want to stay where their church is, they want to stay where their community is, but yet if we don't provide rural health care, we take these great rural citizens and we basically force them to relocate to places that their comfort level isn't there. And so I guess my point would be, yes, we need to fix the private market. I think we're both on the Alexander Murray bill. We think that will stabilize for a 2-year period while we actually have the right conversations about health care. But we also need the federal government to understand that one size does not fit all, that we need to give these great health care professionals, providers, the flexibility that they need, and trust that they really do care about their patients. They really do care about the quality of health care that they're delivering. And they really are amazing people with great capacity to innovate.
So I have 17 more questions. I would like to ask one of them and then give you all an opportunity to ask a couple. So think about what you might want to inquire. We have some fleet-footed mic runners. My final question is to ask you both to talk a little bit about broadband and telemedicine. The president, led by our good friend Secretary Perdue, has just come out with a rural prosperity study which really focused on this question of broadband, and yet again has said we should use, I think it was all viable tools to accelerate the deployment and adoption of high-speed broadband connectivity. Senator Heitkamp, this is something I've heard you talk about as well. Why can't we do this?
We can.
Yeah.
We absolutely can. In fact, Chairman Pai just yesterday announced his proposal for $500 million in additional resources being made available in rural areas for high-speed internet, broadband. What we're really talking about is if you can watch your favorite college team on TV or on a computer, you ought to be able to also provide appropriate connections in emergency situations between professionals in institutions with huge capabilities to make contact with people in rural areas. This is a doable deal. And in fact, let's bring this back in again. The Helmsley Trust. Walter can probably share with you later on today what they've done with e-pharmacy, e-telemedicine, and in South Dakota, we're actually doing that. A number of our major providers, our healthcare providers, are providing doctors on the spot in rural areas, but through telemedicine. This is a doable program. This is not something in the future. This is being done today. But it's got to be expanded, and the capabilities and competencies have to be expanded. Chairman Pai's right. If you put $500 million into expanding broadband into your rural areas, that means not only can you provide better health care opportunities and communication, but you also build business opportunities as well. I remember when I was governor coming in and lobbying the FCC because what they wanted to do was to have two standards, one for upload and download in rural areas and a different one in urban areas. And the urban areas were getting a fair shake. The rural areas, though, for some reason, they didn't need as much upload and download. And my point is I disagree. If you really want businesses to succeed in rural areas, you've got to give them the ability to communicate at the same speed as if they were in an urban area. Get those broadband capabilities up. But something else as well. Let's start talking about fifth generation. Let's talk fifth gen, because when we talk fifth gen broadband, you're also talking about enhanced security. Security is going to be one of the most critical issues when it comes to internet connections in the future. It's here today, but the next steps have got to recognize not just high speed, you've also got to have the security built in so that you can actually communicate back and forth and the bad guys can't get in and cause problems. So as we talk about broadband communications and how they deal with rural health, remember that you've got to have the security built into it as well so people feel the confidence to utilize those systems as well.
Senator Heitkamp, I know you're on a very tight schedule, so maybe a couple words and we can get a question or two.
Great. The couple things. I have what I call the Netflix test. There isn't any millennial who's going to live in any community where they can't stream Netflix. So if you don't have it, then we're failing, right? So you know, I know that entertainment is the interest in quality of life kind of drives this, but behind that is all that business opportunity, all that innovation that Mike was just talking about. What I will tell you that I don't think it's talked enough about is that how connected rural communities are is very disparate in this country. You know, everybody assumes that there's no part of rural America that's connected. I can show you my mother-in-law's farm in rural Stutzman County has better access than some parts of Fargo. So we can't take a broad brushstroke and just cover this. North Dakota has done a great job in rural telecom. Where we haven't is tribal. And so we can't leave the tribal communities behind because access to these services is so critical. But I will tell you that we need a major strategy. I'm going to give a shout out to a colleague, Shelley Capito, who has really taken this on. She formed, and a lot of us are assisted her in forming the Rural Broadband Caucus. She's been driving this initiative along with another number of rural community senators. And we're gonna make this a top priority of infrastructure reform. And so we're in the 1940s, 30s, and 40s. We all talked about getting the last mile of electricity. Now we have to do that in broadband and in communications.
We have time for a couple of questions. Right up front. And please let us know who you are.
Lou Gagliano, independent healthcare consultant. I want to go to the issue of some of the rules that CMS through the MACRA program has initiated and go to the issue of measurements of quality standards, which I think have driven down and concentrated on the fact that if you concentrate on quality, you drive down costs, you benefit everybody. Those rules first applied to hospitals. They're now going to be applying to patients. Insurance companies are using them to direct value-based contracting to those institutions that give better care. In principle, these are good principles. The question is, can they equally apply to rural health care? And if not, how do we get them to be morphed so that they are fair and do drive the kind of principles that we'd all like to see? Thank you.
I'll just give a quick answer to that. This is exactly the issue that drove our demand that CMS really began to focus on rural issues, because we could see the angst coming from providers saying, we don't know what these standards are going to look like. There's a law of unintended consequences. When they're focusing on things that we don't think drive quality, how do we have input? Because the one thing that no one talks enough about, in my opinion, is the fact that what CMS does will always be mirrored in the private insurance market. And so, you know, it's not just CMS and the federal government, it pretty much drives healthcare decision making. And so that's the role, what you're talking about, how do we prevent that from happening? That's the role of this special attention in CMS to rural issues.
I mean, just to lay it out in a way that I think frustrates a lot of our rural communities. If you've got a physician's assistant that's providing care in a community, and you have a local hospital where you have a doctor, but you also have a doctor who is overseeing PAs, at what point and how many times does that doctor and how many of those PAs can that doctor oversee before you risk losing coverages for the benefits of having a PA? We maybe can't afford to have that doctor in every small community, but in many of those communities, that PA provides a valuable service. So does CMS in their rulemaking recognize that a PA may very well be the best that we're going to be able to provide? And as long as there is appropriate communications with a supervising physician, should you now start to cut out the funding because, well, the doctor doesn't have face-to-face rather than a broadband connection? And what about the monitoring? What about when it comes to providing those services in a nursing home setting? Are we now going to be talking about, in some cases where you have a nursing home, you may not have access to all of the professionals because you simply can't afford them, and they're in demand in the larger communities. But if you've got a face-to-face by internet, is there an allowance for it under CMS rules? And there's one other thing. You should never take any one of these rules that's been put in place as being perfect to begin with. Tax law is not perfect. Insurance laws are not perfect. Reimbursement rate laws are not perfect. And none of them should ever be put in stone. If you really want to talk about opioids and the addiction challenges you've got out there, take a look at the guidelines for determining whether or not pain is being appropriately managed and what role CMS has in causing part of that problem. If you walk in and a hospital is asking, or in the surveys that are being asked, how was your pain managed? And you're going to get dinged if somebody says, well, I did have some pain, versus someone who says, nah, they took care of me just fine, man. I didn't feel nothing for days. Well, that may sound really good until you start talking about the addiction rates that go up because of that. And so in some cases, this is a case of where you should constantly be looking back over and finding out whether or not the reimbursement rates, the analysis, the surveys, and so forth are appropriate, and should they be modified based upon the outcomes.
Yeah. Just to play devil's advocate for a minute, if that's quality care in rural communities, why isn't it quality care in urban communities? Maybe that's the problem, is that the rule doesn't make sense in any context, that we're overworking or overpaying for quality health care. Can we do it at a lower level? My husband's a family physician. If you asked him, he would tell you that the days of family physicians are probably numbered, that it's not a specialty that a lot of people would go into because they are being replaced by physician's assistants and nurse practitioners. And so what's our level of expectation as a population on quality of care? Is it always the doctor with the MD is going to be the highest quality and everybody's entitled to that? And so I think we have to be careful that we don't marginalize rural health care by saying it's okay for that rural patient, but not okay for that urban patient.
Let me just hit real quick on one thing, though. If you really wanted to make an impact on rural health in the upper Midwest, take a look at Indian Health Service, or the lack thereof. I mean, if you really want to talk about improving the lot of lives for real Americans who live in rural areas, and you really wanted to see a critical impact and increase in the quality, then take a look at IHS. Because if you want to talk about a healthcare failure, it is IHS. Upper Midwest region, North Dakota, South Dakota, Nebraska, and Iowa. Take a look at why is it that Native Americans in that area have a lifespan which is 10 years less than the average American? Why is it that the rate of diabetes is the highest in the nation? Why is it that tuberculosis rates are the highest in the nation? It's because IHS has absolutely failed. They don't communicate with the tribes that are there. They do not provide the appropriate levels of services. Heck, they can't even tell you how they allocate the resources that are provided to them on a regular basis, except, well, that's the way we did it last year. They haven't had a qualitative analysis of healthcare in IHS since 2008. Now you tell me how you provide true healthcare without having a qualitative analysis that's being performed. That's your federal government at work, or in this particular case, not at work and not being fixed.
So, Senator, that's something we heard quite a bit on our tour. I am quite certain that the senators would rather spend several hours here
Right
based on
about
what is
that.
waiting them back up the street. But I have promised their staff that we'd actually let them do the people's work. And if I could just indicate how appreciative we are, not of just you being here today, but of the work that you do. I think the example that you set is one of the reasons why we are still bullish on the long arc of American democracy. And I want to thank you for spending time with us today.
Yeah, thank you. Thank you. All right.